Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nikam. The feature presentation is various types of premature ventricular complexes, or PVCs as they are called. I've been a cardiologist in Houston for more than 40 years, so let us begin with the feature presentation. Before I go into the actual premature ventricular complexes, or beats as they are called, first of all we need to understand what do they represent. As you can see, here is a diagram of the heart with the atria and the ventricles. Any extra beats arising from the atria are known as the premature atrial complexes. These are complexes because these are electrical representation of the extra beat. The same can be read as premature atrial contractions, which actually represents the mechanical squeezing of the heart chamber. So there's a difference between premature atrial contraction versus premature atrial complexes. The real terminology when we are looking at the EKG is the premature atrial complexes or premature ventricular complexes. We talked about the PACs. If the extra beat is arising anywhere from the right or the left ventricle, it has a different morphology and it is wide. It is having a STT segment going in the opposite direction, and there is no preceding P wave as we see with the premature atrial complexes. So these are known as the premature ventricular complexes. Depending upon how frequently these premature ventricular complexes appear and in what sequence they appear, there are various terminologies that we need to be familiar with, which is going to be the main focus of this presentation. Here is an example of a normal heartbeat. A wide QRS complex with an STT segment in the opposite direction with no preceding P wave. So this is a premature ventricular complex. And again, we have 3 normal beats and another extra beat. If the premature ventricular complexes are occurring like 1 to 2 per minute, they are known as rare ventricular premature complexes or beats. If they occur at a frequency of greater than 6 beats per second, they are known as frequent premature ventricular complexes or frequent PVCs. So that's an important term you need to remember. Not always these extra impulses arise from just one part of the heart. When the heart is sick, the entire heart muscle is sick. So every region of the heart muscle can be irritable and they can produce extra beats. In some cases, we can have extra beats arising from 2 or 3 different sites, and that's where we get this what is called multifocal PVCs. Here we have a PVC going in the direction of the QRS complex, and we have a different morphology QRS complex, and none of these are preceded by P waves. And here's another one which is a totally different morphology with probably a retrograde P wave, that is the ventricular complex activating the atria after the ventricles are depolarized. So this is known as the multifocal PVCs. You have to understand the difference between multifocal PVCs and unifocal PVCs. They have different morphology, they occur at different intervals, and they can be in any direction. Here we have 2 beats coming one right after the other. Here an focus in the ventricle fires an extra beats, and a few milliseconds later it fires another extra beat. So we get 2 complexes. They may be identical or they may be of different morphology depending upon where the impulse is arising and how the impulse is conducted and what the refractory period is because of the previous ventricular depolarization. Anyway, this is a ventricular couplet, and we need to contrast the ventricular couplet with another terminology called ventricular bigeminy. Here we have a normal heartbeat, we have a wide QRS complex followed by a pause. PVCs are characterized by what is known as the post-PVC pause, which is an important element when we are trying to differentiate between a premature ventricular complex with an atrial complex with an aberration, where you do not see a prolongation of the cycle, whereas with the PVC, you get the cardiac cycle reset. So we get a long pause. So we have a normal beat, we have an extra beat, normal beat, extra beat, normal beat, extra beat. So this is a ventricular bigeminy. Now let's contrast ventricular bigeminy with the ventricular couplet. Here we have the same example of ventricular bigeminy. We have a normal beat, an extra beat, normal beat, extra beat, whereas ventricular couplet is two ventricular complexes occurring in close succession between the sinus beats, or it could be atrial fibrillation. The underlying rhythm could be anything. So you have to know the difference between ventricular bigeminy and ventricular couplets. The next thing we're going to look at is when you get three ventricular complexes in a row. That means here's a ventricle that is firing an extra beat, again it fires an extra beat, again it fires an extra beat, so we get three complexes in a row. This is known as ventricular triplet. Anytime we get more than 3 beats, that is if we have 4 beats or more, it is known as short ventricular tachycardia versus ventricular triplet, which has 3 consecutive ventricular extra beats. Here we also see something different, and that is we see a ventricular couplet here, then we have a normal beat, we have a ventricular triplet here, we have a normal beat, then we have a normal beat which was trying to come here, but that was overshadowed by the ventricular couplet. When we see something like this, this should be an ominous sign that we are dealing with a heart that is much sicker than a heart with just occasional PVCs. Let's look at a different terminology that is used to recognize the PVCs. Here we have a normal beat, extra beat, ventricular premature beat. Normal, PVC, normal cutoff. So this is known as the ventricular trigeminy. That means every third beat is an ectopic ventricular complex. We need to differentiate this with the ventricular triplet, because in an exam, you may be in a rush and you may inadvertently pick the wrong answer. Even though in your mind you are thinking this is ventricular trigeminy, you may click ventricular triplets. So let us look at the difference between a ventricular triplet where all 3 beats occur one after the other, whereas in trigeminy there are 2 normal beats and an extra beat, 2 normal beats and an extra beat. Let's remember that. Anytime we have 4 or more complexes, then we are talking about short burst of ventricular tachycardia. When we are talking about short bursts of ventricular tachycardia, we have to think about not only ventricular tachycardia, but also we need to consider supraventricular tachycardia with aberration. And the supraventricular tachycardia could be a regular tachycardia like a PAT, or a flutter, atrial fibrillation, which is irregular. That means if you have a VTach, a short VTach, there is no preceding P wave, or the P wave may not be conducted, or this is a fusion beat, and that triggers the ventricular tachycardia. Generally, the ventricular tachycardia, the ST segments are in the opposite direction, the QRS duration is wider, and the RR intervals are fairly equal in time. Whereas with supraventricular tachycardia, they can have an identical picture, but it may be preceded by a P wave also. The only way to find out is see if this person has any underlying bundle branch block or any evidence of aberration when you see only 1 extra beat. Whereas with atrial fibrillation, you can have a similar tachycardia in the presence of atrial fibrillation, but that is usually followed by an irregular RR interval. So let's remember these points because they can give you a rhythm which looks very different with RR intervals being varying from cycle to cycle, wide QRS tachycardia in the presence of a rhythm which you don't know what it is because you don't see the definite P waves. If you have an irregular RR cycle here, if you have an irregular RR cycle here, chances are you're dealing with atrial fibrillation with aberration. If it happens to only one beat, it is called Ashman's phenomenon. You usually see that when you have a long cycle followed by a short cycle that leads to increased refractory period in the bundle branch that leads to Ashman's phenomenon or a bundle branch block pattern, which is most oftenly right bundle branch block pattern. Whenever you see a wide QRS tachycardia, we should always keep in mind the possibility of a supraventricular tachycardia with aberration. You always go back and look at long strips before the arrhythmia started. If you're seeing similar morphology in an extra beat, single beat or two beats, and that might help you to identify whether this is supraventricular or ventricular. Here is an example of a sustained ventricular tachycardia. Whenever you see a sustained ventricular tachycardia, you have more than 4 beats or maybe 16 beats where you see a wide QRS tachycardia, generally less than 200 beats per minute, and you have a regular RR interval and the STT segments are going in the opposite direction. And whenever we see this, again, we need to think about the possibility of a supraventricular tachycardia with aberration. It can happen in patients with PAT when they have an underlying bundle branch block. It may look like a ventricular tachycardia. Here we have a short run, or I would say a ventricular tachycardia, but the morphology QRS complex is shifting. Here it looks like it's going up, and here we don't know, it's intermediate, it changes the axis, and it is going down now, the QRS complexes. And again, the RR intervals are not really constant. This is an example of a polymorphic tachycardia, polymorphic ventricular tachycardia, or it could be torsade. There should be ES that is missing here. Torsade, and that is something we have to keep in mind. Whenever you are looking at a patient with a rhythm like this, we know this is an extremely sick heart, and it can also be related to the drugs, the antiarrhythmic drugs they are getting, because some of the antiarrhythmic drugs are arrhythmogenic by themselves that can cause torsade. And here is an example of a torsade where we have a QRS complex which is going in one direction, it shifts the axis, it is going in another direction, the rate is faster, the QRS morphology varies from beat to beat, and this is an example of an advanced ventricular arrhythmia and usually represents a very significantly sick heart. So ladies and gentlemen, this is a quick synopsis of what are premature ventricular complexes, how they differ from premature atrial complexes, and the various terminologies used to describe the relationship between the sinus beats and the ventricular ectopic beats and the various types of supraventricular and ventricular tachycardias. Thank you so much for watching this presentation, and please do subscribe to our YouTube channel. I will see you in the next presentation.